Hi guys, welcome to another video from urologyresource.com, and in this video I'm going to focus on the assessment and management of the patient in acute urinary retention. This is a really unpleasant condition and results in a patient who is unable to void despite having a full bladder. It's usually really painful and the patient is often quite distressed by the time they reach hospital. Typically we see acute urinary retention in older male patients. However, it's not that uncommon to see younger male patients or indeed women in retention. As with all surgical emergencies, it's important to take a really good history and perform a thorough examination. Often this can be very difficult in a patient who's in acute retention as they're so uncomfortable. Therefore, sometimes it's best to treat them by passing a catheter to relieve the retention and then coming back to the history. We'll come on to catheterization in a minute, but in terms of the important features of the history, it's really vital to get an idea of any background lower urinary tract symptoms, particularly in older men. So as we discussed in another video, they may have a long history of gradually worsening voiding symptoms such as hesitancy, poor stream, incomplete emptying and post-micturition dribble. They may also have symptoms indicating a more recent infection, such as burning dysuria, smelly urine, possibly hematuria, and it may well be that the UTI has tipped the patient into retention. Visible hematuria, particularly with clots, is important, as some patients have a phenomenon known as clot retention, whereby they have, for example, a large renal or bladder tumour which has bled a lot into the urinary tract, resulting in clot formation, and it's these large clots which block the bladder outflow. Other symptoms that may be important are neurological symptoms and back pain. There is a particularly unpleasant condition called cauda-equina syndrome, which is usually the result of a vertebral disc prolapse which compresses the cauda equina. You remember that's the horse's tail set of nerve roots from the lower part of the spinal cord. It's important to recognize this condition, and retention may be one of the earlier presenting features. If it's not picked up and treated by means of referral to a spinal surgeon for spinal decompression, the patient may end up with irreversible neurological damage, including paraplegia and permanent bladder and bowel dysfunction, which clearly is a disaster. So definitely ask about any new neurological symptoms. Retention may also be a way in which multiple sclerosis presents, and in fact, urinary symptoms are the second most common mode of presentation of new onset multiple sclerosis. In women in retention, it's important to ask about any new gynecological symptoms, as occasionally large pelvic masses can cause retention. So certainly ask about any period irregularities or postmenopausal bleeding or intermenstrual bleeding, and any abdominal pain and bloating. Other things that are important to note are the commencement of any recent new medications, such as opiates or anticholinergics, both of which are drugs which may result in retention. In older patients, it's important to ask about bowel habit, particularly constipation, as this can precipitate retention. Moving on to the examination, the general examination will usually reveal a really uncomfortable patient who's tachycardic, but usually not pyrexial unless they have a rip-roaring UTI. Abdominal examination will usually reveal a palpable bladder, which is felt as a midline solid mass arising out of the pelvis into the suprapubic region. It's usually dull to percussion. In some patients, particularly those with a high BMI, it may be difficult to feel a bladder, and in those cases retention can be confirmed by performing a bladder scan, although do remember that the less sophisticated bladder scanners can be fooled by other pelvic fluid collections, such as large ovarian cysts or even abdominopelvic ascites. It's important to conduct a thorough neurological examination, including an assessment of perineal and perianal sensation and anal sphincter tone. It's also important to document lower limb sensation, tone and reflexes. In male patients, clearly it's important to examine the prostate, both to assess the size as well as to decide whether there's any clinical evidence of prostate cancer. We've already mentioned that these patients need urgent catheterization to resolve the retention, and this is usually fairly easily done with a urethral catheter. We'll talk more in another video about catheterization and the difficulties that you may encounter when catheterizing a patient. Once you've catheterized a patient, you must make a note of the residual volume of urine which comes out, and in acute retention this is usually between 500 mils to a litre. If the patient has more than 1.5 litres, there's usually an element of chronic retention, which is a different entity, and again we'll discuss this in another video. I'd always recommend dip testing a sample of the urine soon after the catheter is put in to look for UTI, and if there's any doubt, send off a sample for microbiological culture. I'd also recommend some bloods, and in older male patients I'd recommend a PSA. This is a little bit controversial, as some urologists would argue that the catheterization itself puts the PSA up, which I think is true. However, if the result comes back showing a PSA of several hundred micrograms per litre or even several thousand micrograms per litre, then I think there are very few conditions other than advanced prostate cancer which would give this reading. In female patients, I'd organise a pelvic ultrasound scan through the transvaginal route to look for any pelvic masses, and if I'm worried at all about the possibility of neurological disease, I would immediately discuss the patient with my spinal surgery colleagues and organise an urgent MRI scan to look for cauda equina syndrome. The subsequent management of the patient with a retention very much depends on whether they have any reversible factors. So, for example, if they have a clear-cut UTI or they've been recently started on some medication which might have resulted in retention, these need to be addressed before you take the catheter out. In younger male patients or in female patients, there usually is a clear identifiable precipitating feature. However, in most of the patients you'll see, i.e. older men, the cause of the retention is the bladder outflow obstruction caused by the enlarged prostate. And in these patients, there is good evidence that it's worth starting them on an alpha blocking tablet, an alpha antagonist, prior to trying to take the catheter out. These include drugs such as doxazosin, tamsulosin and alfuzosin, and they all work on the alpha adrenergic receptors on the smooth muscle of the bladder neck and in the prostate. These tablets tend to open up the bladder neck and prostate a little bit, which results in a higher chance of the patient being able to void, and this has been borne out by a large randomized trial from a few years ago. You need to give the patient at least 48 hours of alpha blockade before taking the catheter out. At that point, if they can void once the catheter comes out, then this is really good news, and I would see them in clinic further down the line to make sure that their lower urinary tract symptoms aren't bothering them too much. If, however, they go back into retention after you take their catheter out, then they need to be recatheterized, and consideration needs to be given to surgical treatment such as a transurethral resection of the prostate. This is an operation which is conducted endoscopically and essentially debulks the prostate, opening up the caliber of the urethra. This is a really good treatment for patients in acute retention who fail a trial without catheter, and usually results in the re-establishment of normal voiding. Even patients who manage to void immediately after the catheter comes out have a high risk of going back into retention within the next 12 months or so. So I think it's important to warn them of this, and if they do go back into retention again, they would be potential candidates for a TURP. So to summarise, acute urinary retention is a common problem, and whilst mainly seen in older men with enlarged prostates, you do see it in all patient demographic groups, and it's important therefore to think about some of the other causes, including neurological disorders, UTIs, drug therapy, etc. Management is usually straightforward with the introduction of a urethral catheter, which gives immediate relief. We then focus on the underlying cause of the retention to try and eliminate that, and then remove the catheter. I hope you found the video useful, and if you have, please subscribe to our channel and hit the like button. I will see you next time. Thanks for watching.